Now, without any further delay, I'd like to turn today's program over to your presenters, Matt Kibbe, Director, Market Intelligence Group, James Hamilton, Leader, Social Media Group. Matt, the floor is yours.
Thank you, Mike. What I wanted to do to begin was just to say a very warm welcome to everybody. Thank you very much for joining us today. We realize that this is actually quite early in the United States, but of course we've also got a lot of people from Europe and from Asia, as far as Asia too. In fact, I think we have about representatives from 18 countries on this call, so we're very excited to be able to share this information with you. Thanks again for joining us. So I'm going to get straight into today's webinar. What I really wanted to begin by saying was that I have a general assumption about why most of you are on this call or joining us on this call, and that is that each of you is in some way involved in feasibility studies, and you're here because there's some general recognition that the current model of feasibility analysis and prediction of site performance is some way flawed or can in some way be improved. I just want to make it very clear from the start, however, that we're not going to be talking about a new surveying method or way of looking at historic performance data or using health claims data from various sources or ICD-9 or ICD-10 codes or anything like that. I think that there's a general sense that that's a topic that may have been done to death, and you all have your own unique ways of looking at that kind of raw data. So what we want to focus on today is the thing that excites us, the evolutionary step in feasibility modeling, and that is the way in which social media can provide us with a whole new opportunity to refine whatever model you currently use further by adding the often forgotten voice of the patient into the mix. Okay. Now, so what we're going to do today is we're going to be looking at the conventional study feasibility model very, very briefly, just to identify what the deficiency commonly is, i.e. what's the current environment and what's missing. Then we're going to be looking at how and why we can integrate social media into the new model, looking at addressing the deficiencies by creating a new model and adding social media into that mix. Then we're going to be looking at social media tactics. It's an examination of the way that we can apply social media to the feasibility model. And then finally, we're going to be looking at best applications for this information beyond feasibility. It's not just about feasibility, and we're going to talk just a little bit about how we came into the understanding of how this information can also be applied vertically into the patient recruitment and retention conundrum, protocol design, country selection, media planning, retention ideation, all of those kinds of things, so that the information can be amortized across the whole patient recruitment landscape. So I'm going to get right into that. First off, I wanted to also mention that I think that we need to have a common point of reference quickly before we proceed, and that is to say that we're specifically talking about recruitment feasibility as opposed to other forms of feasibility modeling. And those other forms of feasibility modeling are things such as operational, medical, strategic feasibility that you can conduct on any kind of clinical study. And in this sense, we mean it is our ability to forecast probable enrollment rates and the application of this knowledge to help us predict the numbers of patients we would see over time at a given number of active sites. I guess the whole idea is bound up in the notion of the general recruitment feasibility formula of E equals RTS, where E is the number of patients, R is the recruitment rate in patients per site per month, T is the amount of months you have, S is the number of sites. And within that sort of general principle or that formula, you can determine the probability of reaching your enrollment goal within the desired time parameters. So also from this process, of course, it's possible to identify sites and begin the process of validation and site selection. And so that's really what we're focusing on today, of course. Now, here's a conventional model. This is what we see as a sort of an overview of the conventional study feasibility process. This is not BBK's feasibility process, and we've talked extensively about the way that we would remodel this, or the way that we do this differently in many different settings. And we've done talks at the DIA and other conferences to address this issue. But as I've mentioned, to some degree, what we're talking about today is not caught up in surveying sites or using historic performance data, ICD 910 codes, read codes in the UK. We're talking about getting an estimate of available patients that can then be transferred into an estimate of the total number of enrolled patients per month for all sites. Now, what we see here, what we notice here is that even though there may be different ways that are employed to gather the raw data, there are 80 people on today's webinar and teleconference here, and I'm sure that there's 80 different ways that you all use to gather that information. But I think what we can commonly agree on is that there is a glaring weakness in this model. Every single one of us who's involved in feasibility works very hard to get to point 2 on this slide. And then we all also usually acknowledge, when I'm talking about this in other fora, is we apply what I would say is an arbitrary or anecdotal or unsystematic, but certainly inexact discount to the number of patients that we estimate are available at sites in order to determine a probable value of R, the recruitment rate. And usually that's simply dividing the number in 2, or by dividing in by 2 and then by 2 again. And it seems to me a little odd because we worked very hard to get good data up to the point of number 2 on this slide, and then we kind of spoil the scientific nature of our investigation with that kind of discounting. Now, I know that some of us are going to be holding our hand up and saying that we do that. But there's really inertia to change. We've identified this problem for a long time as an industry, but we tend to go on tolerating this notion too. I've spoken with many people, and the irony is here that when we're in a greater rush to get this information, and that is to say that we want to do more with less resources, our default is to doing things the same way that we've always done them, and that is to just repeat this model and then still make the educated guess. How can we improve this conventional model? Well, I guess the glaring weakness isn't just that we have this big educated guess in the middle of the process there. It's also that this whole model is focused on the site and the information that the sites can give us. And that is not to say that that's an incorrect thing to do. I think that we all have to understand that using information from the sites, building trust with sites to ensure veracity of data is very, very important. But we also have to add a third dimension to this, and that is to bring the patient's information back into the system. To the extent that analysis of patient information occurs, it usually includes data, but it does not usually include perspectives, motivations, or needs of patients. It may also include physician feedback, but that's not directly from the patient themselves. And I think that what we're trying to posit here is that without this information from the patient, we simply cannot make the last leap in a feasibility estimate to get an exact number of R. Because once you know the eligible number of patients within a patient panel, you still have to be able to understand whether a patient who is approached with this information is likely to make a choice to join the study, to go through the consenting process and actually be an active participant all the way through to any endpoints. So with this in mind, we restate what should be the conventional model. And here you can see that data aggregation should occur on parallel tracks, simultaneously estimating the contribution of eligible patients and aggregating data from the sites to estimate the number of patients likely to enroll from the given panel. Now, this sort of right-hand track, if you will, is what we're going to be focusing on today, the contribution, the motivational probability of patients who are eligible in selecting participation in the study as their treatment option. Bringing those two parallel tracks together to provide us with an informed appraisal of what feasibility could be, rather than an educated guess of how patients will react to that information. So adding these two pieces of data accomplishes our goal of taking two-dimensional information, making it into a more complete portrait of what is likely to happen in the study, removing educated guess from this equation, making it more three-dimensional, and combining both site and patient-focused data sets so we can then have a more informed view of R.